Tuesday, and welcome back to another episode of MSLead Chronicles, where leaders learn from leaders. I'm Mary Morton, and along with my buddy Chad Fellers, we have casual talk about the challenges and successes in medical affairs with the most exciting and impactful professionals in pharma. As always, we have another great one for you today, so stick around.
Hello and welcome back to another episode of MSLead Chronicles. I'm your host, Chad Fellers, along with my nifty sidekick and baby blue today, Mary Morton. How are you, Mary?
I'm doing good. How are you doing?
I'm doing really well. I just got back from Cabo, so I'm a little darker, I think, than when I was before I left. It was hot. So it was like the pools were like warm bath water. So that wasn't necessarily the best thing, but you know what? The Miami Vices were really good. And had a good time. So how about you? What's new with you?
Well, let's see. I'm getting over my my post World Cup depression. And sadly I'm sorry for Norway and England and the United States and Argentina, because when I watched, you guys lost, and I take partial responsibility for that. But yeah, it was, I think it was more than the Olympics to me this time, watching the World Cup.
I had no idea what the World Cup, I gotta be honest with you, I don't know anything about soccer, but I got sucked into it. It was a lot of fun to watch, but like you, I was there when the U.S. lost, and it was fun though watching it in Mexico, though. The final was a lot of fun. So anyway, all that being said, it's good to be back. Excited to be with you again today. Have another casual conversation, all things medical affairs, and this is going to be a fun one today for me, getting to connect with one of my colleagues and friends. So without further ado, we're going to talk about the rare disease space and why patients matter as we're thinking about strategy and planning, specifically from medical affairs. So without further ado, why don't you introduce our guest to our listeners?
I am happy to. So today we are joined by Teresa Fecteau, and she is a medical affairs leader with nearly 20 years of experience working at the intersection of science, strategy, and patient partnership in rare disease and in ultra rare disease. So throughout her career, she has helped turn complex science into medical strategies that support clinical development. Then also launch readiness, scientific communication, and ultimately, hopefully, better outcomes for the patients and their families. Before moving into industry, Teresa worked as a clinician, a researcher, and an educator in academic medicine with the VA. She got her PhD in clinical psychology from the University of Maine and completed her residency and postdoc in the behavioral medicine department at Duke. And so my daughter, by the way, just for sidebar, she got a psychology degree, and she did all of her Duke tip stuff at Duke. And so she would have loved to have gone to Duke, but I wasn't paying out-of-state tuition. So, so these days, Teresa is focusing on advancing therapies in genetically mediated rare neurologic and neuromuscular diseases. At the center of everything for Teresa is what she refers to as her simple philosophy: patients first, always. She is especially passionate about making sure that the lived experiences of patients and their families help to shape research, development, and the strategy from the very get-go. So welcome to the show, Teresa. So glad you're here.
Thank you, Mary. Such a privilege to be here. I'm really, really excited to be having this conversation with you both today.
Yes.
What do you mean, Teresa? I mean, we're just basically inviting people into the conversation we have just about every day, right? So
it's very true.
Selfishly,
Chad.
I get to work. I've put up, Teresa rather has put up with me for several different stops between Biogen and Avidity, now a Novartis company, and I couldn't shake her, or she couldn't shake me one way. I don't know how that was, but yeah, she's a lot of fun. So, all right, Mary, I know you've got some things that you want to ask Teresa before we get things kicked off. So let's get at it.
Yes, and I'm deliberately asking my questions in a different order this time.
Ooh,
Okay.
okay. All right.
Ooh,
So-
put me on the spot. Uh-oh.
Yes, ma'am. Okay. So a pilgrim, Paige helped me come up with this one. It's really good. A pilgrim is transported through time and you get to spend the day with them. You are responsible for deciding what you do, where you go, what you're going to show this pilgrim.
Mm,
What's the first place you're going to take them?
a softball game, a women's college softball game.
Okay. All right. Well, you just teed up my next question. So, it's sort of a two-parter, so like no need to answer right away. So, if you are familiar with a sports league that's called Athletes Unlimited Softball League, I'm just curious what your favorite team might be because I know which one is mine.
Oh, you do. That is impressive, Mary. We'll have to have that offline conversation. My favorite team is currently the Volts because my niece plays for the Volts. Michaela Edenfield, she's one of their catchers and my absolute most favorite player in the world. So that's an easy one for me.
Yes. Exactly. And I knew that. Michaela Razzle Dazzle.
Yes.
She's well known for, she's got to hide behind that catcher's mask. She's got to have all her glitter and glam on her face.
That's right.
Okay. And so for the people who did not know, Teresa was also a college softball player and she played for Florida State. Where Michaela also played, right?
That's right. That's right.
So did you guys have walk-up songs?
We did. Very different than the era of what they do now. But I think actually our media person chose mine, and I don't even really remember what it was. I think it was like, I don't know, it was like the Rock's walk-up song for like wrestling, which I had no connection to. So I have no idea.
I don't know what that is.
It's what they thought fit, I suppose. So,
So what would it be? If you got to pick it today, what would your walk-up song be?
Yeah. I think for me, well, Chad, you know this about me. I'm a bit of a 90s, early 2000s hip hop fanatic. So strangely, like probably nobody would guess that. But I think for me, it would probably either be Jay-Z, Dirt Off Your Shoulder, especially thinking about rare disease activities and like the resilience that it takes to face the adversity, or almost anything Missy Elliott. Like all I want to do is dance when I hear Missy Elliott. So probably like something like Lose Control or something like that would be for me. Work appropriate options.
I thought she was going to say OPP in honor of all of her work with
No,
OPDP. OPDP. Are you down with OPDP? And all of
no. Okay. Accelerated
Yeah.
approval. Oh my goodness.
Yes.
Right.
That was with rare too. Anyway, all that being said, do you have another one, Mary? Are we good?
No, but I just have to go back to the Texas Volts. So the Texas Volts, they at the helm is Cat Osterman, who played for University of Texas.
Mm-hmm.
And they play just right up the street in Round Rock. So at the Dell Diamond.
That's right.
So they're our team.
That's right. Yeah.
So Michaela gets to be one of ours too.
That's right.
All right. So I am done with my rapid fire questions.
Hey, you could get an autograph. I bet she could help hook you up with an autograph maybe or something, Mary. So next time you're there, right?
That's
right.
So yeah. Or some makeup tips. Some of those makeup tips. Not that you need makeup tips. Don't go there. I'm not suggesting
no,
anything.
I'm not.
But
I could never pull off. My daughter could, but I could never pull off what Michaela wears. It's gorgeous, but I'm too old for that.
I could never actually make it happen. If I tried, I would just look like a clown. So we all know that would go a bad direction.
Yeah. All you gotta do is Google her.
Yeah, just Google her. She's great.
Beautiful makeup that she does. Okay.
Yeah, beautiful.
So
picture. All right. So, really interesting conversation around walk-up songs, etc. I'm trying to think of a good segue, but I guess before I even try to segue into things, we teed it up earlier talking about the importance of patients and rare disease and how we integrate them in medical affairs. But Teresa, as tradition, we like to start with key takeaways for our listeners. So do you have a couple that you want the listeners to walk away with today? And what would those be?
Yeah, thanks, Chad. I mean, I think for me, if there was just one thing that I could have people walking away with today, it's it's really the concept that putting lived experience at the center of what we're doing. It's not something that we do. It's not something that we do that ends with a project or an initiative. It's really a mentality. I think it's a consistent North Star. And it really requires that intentionality, the commitment to building trust over time, and really ensuring that we're putting systems in place that allows that lived experience to challenge our own assumptions. And I think the two key points of that for me are really when we successfully move beyond engagement to a truly intentional partnership with rare disease communities that we're serving. What we're doing in that is enabling innovation that's grounded in what matters most, what matters to the people that we're serving, the patients and families that are managing through these diseases. And then second, the lived experience, it really is the roadmap, right? It's a roadmap for innovation in rare disease, and medical is really uniquely equipped or positioned to translate the insights that we get from these communities or that we learn from these communities into meaningful action that helps us drive, as Mary said before, really drives those outcomes. That's what brings us all here every day to do what we do, right? So if we're really focused on the patient, I think we have the best opportunity to improve outcomes.
Actionable insights. I just heard that. So you now piqued my interest on this. One of my favorite passions. So, all right. So let's open it up really with why lived experience. You mentioned that you used that phrase a minute ago, why that matters in rare disease. So, as you know, data is often scarce in rare disease. So when we're thinking about the lived experience, why is that foundational rather than simply a nice to have? Why is it really important in rare disease?
Yeah. Well, I mean, if we think about the definition of rare, right? Rare means not a lot. So we've got small populations. They're highly heterogeneous. We often don't understand too much about the natural history or course of these diseases because we don't have those large, complex data sets to tell us almost everything we want to know. So I think when data is scarce in that way, particularly when you start getting into genetically mediated diseases where, one mutation might cause a disease, but there's a limitless number of mutations within or variants within that mutation. The voice of the people that are living or impacted by that disease, and that includes the person who was identified as the patient as well as their loved ones and care partners, right? It's not nice to have. It's truly foundational. If we're not paying attention to that, I think our ability to kind of fill the gaps that data sets probably will never be able to fill in these conditions because they are so very hard to capture in that way. But unlike really common diseases, I think the medical system, the research engine, et cetera, is learning from people with these rare diseases, not the other way around, right? If you go to a medical facility to treat something like hypertension, we know a ton about it. We know what to do. We've got many, many options for treatment. That is not the case in what has kind of come to be known as these zebra diseases, right? So the lived experience is always going to precede scientific understanding, but the science is much harder to catch up when we don't have a lot of people to study or that we know about to study, right? So the systems really are learning from patients and their care partners long before they have the capability of benefiting from what's being learned, right? So I think the ability to listen in that way, it helps us to learn fast. And I think to me, that's the commitment in rare disease, is not to have all the answers, not to promise answers or solutions, but to really be committed to listening intently and learning as fast as possible so we can get to some meaningful solutions.
You're talking about, we've got to learn. And so I do a lot of work I do a lot of work like I do like what you guys do, but I do a lot of my recruiting projects are with rare disease companies. And so I can tell the difference when I'm talking to like an MSL that is not working in rare disease. That there are pieces of the puzzle they don't really they really aren't, I don't want to say they don't understand, but they're not as familiar with. What do you think that people who live their life outside of rare disease in pharma or in the community understand the least or misunderstand about what that burden is like for the patient and the family, or what it's like to go 7 to 10 years and have no idea what you're living with.
Yeah, no, I think Mary, what you just said is really at its core. I think that patient journey, or in the rare disease community, some groups prefer more of the diagnostic odyssey language. Wherever you fall on that spectrum, I think that's so critical. You know, in rare disease, very much different than common diseases. The diagnostic journey or odyssey is really often, most often measured in years, not months. And in some of these diseases, I mean, I'll speak to one that's very near and dear to my heart in terms of work that I've been privileged to do over the past few years in the ALS space. A lot of the variants in ALS are extremely rapidly progressing, you know, and when you're talking about a disease that could potentially take you away from the world in 2 to 5 years, you don't have 8 years to wait for a diagnosis, right? So the time to diagnosis is not just a time to understanding what is going on with your body. It's also a time that gives you the opportunity even to consider treatments or to consider trials if there are no approved therapies. So it's you know, I think that journey is so important, and it can be so prolonged, and it's not just about understanding what is the title of what is going on, what is the name of what's going on for me. It's that journey that leads people down misdiagnosis, procedures that are not really necessary, things that could potentially cause additional damage to your body, right, or trigger something else happening. And for medical providers, I mean, we all know this in this world, we live this world every day, but providers are rightfully taught the adage of, you know, if you hear hoofbeats behind you, don't turn around expecting to see a zebra, right? You should expect to see a horse first, and then you maybe look for the zebra later. And that's a really important thing to avoid some of the you know, like missing some of the common things. But then on the flip side of it, right, we miss the opportunity to more quickly identify what could be a more easily identifiable rare condition. I think especially in the era that we're in now, where the implementation of genetic counseling and testing is more common. Well, I should say maybe the implementation of genetic testing is more of interest to people, but the genetic counseling is probably a little bit lacking, and that's truly what is going to help to empower and inform decision making. So I think that the journey and all of the pain that goes along, pain by physical pain, pain by financial pain, you know, the burden of disease, the burden of care, the burden of travel to centers of excellence when you're a person who lives in a rural community. All of those things are typically underestimated until you're actually living that world. So really, really important journey or diagnostic odyssey considerations there.
I didn't even think about that. The burden of getting to a facility where you can be treated by somebody who knows how to treat what you have.
That's right.
I'm sorry, Chad, I didn't mean
No, don't apologize. Yeah, you talked about the system. I think systems, just by design, even the way the expectations now, from general practice to, you know, you got 5 to 10 minutes per patient, et cetera. You don't have time to do that. I'm wondering, it just makes me think, I wonder if AI will help accelerate some of these things as well too. Maybe being able to record this, to be able to pull different key things to help people think about things beyond. Maybe that's something that the medical community will embrace, which will help close that gap a little bit. I don't know, but I would definitely think that's an opportunity, certainly. But you mentioned about the system learning from patients that live or support those with rare disease.
Yeah.
How have you seen it, knowing that you've had additional background beyond rare disease? How do you see it change the way that medical affairs should to approach things in our perspective? You briefly talked about it on your key takeaways, but could you go into a little bit more detail?
Yeah, I mean, I think it really, you know, learning from these individuals or being committed to learning from these individuals versus coming at it in more of that sort of problem focused, I'm here to fix what's going on. Because in this world, you don't always have a fix, right? You don't have the answer for what's going on. You don't even always know how to identify what's going on. So, and I think in the medical landscape, you know, we talk a lot. And I know you and I have personally had conversations around so much of, you know, what are we doing in medical affairs, and how do we measure it? How can we get to that place where we're measuring impact versus activity and what really matters in the world? And I think, medical, whether you're an MSL or an internal medical leader, so much of what we do is about relationships. But in rare disease, I think that listening, that really intent, continuous listening and learning is grounded in so much more than the relationship. It's actually a foundational scientific activity. And so without implementing a way to do that consistency and with very specific intention, we don't have the ability to be continuous learners, which I think is where we excel if we do this well in rare disease, whether you're medical or other, but particularly in medical. And I think one of the things we have to do here, from my perspective, is that, we've got to think about asking questions and then listening for answers that really are intended to challenge our assumptions, which means we have to know what our assumptions are, right? And I think if we can go at it and really, really intentionally dig deeper, dig below that surface with a good amount of courage, the gusto that it takes to think about asking even the question to these people with intensive lived experience, what hasn't been looked at? What am I not asking that I should ask? What do I need to know that I don't know that I don't know, right? All of those things are so very important. And I think if we can approach every conversation that we have, internal or external, with this sense of wanting, or maybe dare I say even hoping, that our assumptions are going to be challenged, I think we have the ability to really advance the field more rapidly. And that kind of deep listening is really going to teach us more than any publication, in my opinion, could ever teach us, because it's going to be so far ahead of a publication, but it also requires more data than an N of one example.
Yeah.
How do you so you guys are in Duchenne muscular dystrophy, and that's actually the Cure Duchenne organization is something I'm really involved in, and that's a lot of moms and dads and grandmas. Like probably one of the fiercest women I know is a grandma, and her name is Kate Meyer Mobell. She's out of Dallas, and she raises a lot of money directly for the clinic that her grandson goes to. Anyway, that aside, but if the rare disease is children, they're so young they can't really speak for themselves, or they don't know how to tell you how they're feeling or what they're dealing with, or how do you engage the caregiver or the family to speak on behalf of those who can't? That's a really long question. I hope that makes sense.
No, it does. It does. And I think it's imperative. And, for very young children, I think it's a bit more organic, right? Because as a clinician or a researcher, a 1-year-old they're just not physically able at that point in life to speak for themselves. So I think that's a bit more organic, but I think it's not easy. It may be organic, but it's not easy, because we also have to think about what questions are we asking. And, one of the things that I try to really live by the code of is, we think we know when we're designing strategies. We have really well-informed information that is driving us to that strategy that we align on, right? A lot of very smart people aligning on strategy. But I think if we ever get to the place where we assume we've got it all right, and all we are doing is going back looking for confirmation, that effectively is a confirmation bias, right? So what we ought to be doing is co-creating this. And I think the same goes whether you're gathering clinical information. I think the North Star as a clinician is like, how good am I at collecting accurate, reliable information at the bedside or in the clinic room, wherever you are. And I think the same rules apply in our world. Like, how good are we at really getting that accurate, reliable information from the source, right? And there are obviously within compliance guardrails, but I think we have to really think about collecting that. And that could be from a parent, it could be from a care partner, it could be from a number of care partners or folks that are involved in that patient's life. I think it gets more complicated. I'm sorry, Chad. I think it also gets more complicated when we're talking about, as we begin to see more therapies coming online, especially for pediatric rare diseases that prolong, hopefully, quality of life, not just years of life. that becomes incrementally more challenging when patients are moving through transitions of life, right? I mean, we all were teenagers at one point. That was a few years ago for me. So,
A
but there are
long time
points.
for married,
Yeah,
long time for
right.
married anyway.
There are points in your
True,
life
though.
that you don't necessarily want that parent to be involved, but from a research and clear understanding standpoint, that's still really important. So I think we have to work with the community to understand how to effectively get information that is truly valuable and meaningful to help us move forward.
You said a couple things there, and I'm going to ask some follow up questions around one of them. But your last statement just brings to mind the whole transition of care for the SMA population, right? So now that they're living
Yeah.
longer, and they have caregivers going to we fought that fight. Like, how do we actually empower these patients living with SMA to be able to have their own conversations? Because when they hit 18 or
Yep.
25, maybe, right, and they're transitioned out, they can't be seen by a pediatric provider. Their caregiver really can't drive a lot of the conversation, or they own those things. And so how do you even navigate that? It's a great problem to have in ways, because these patients are living longer, but how do they thrive, right? So it's just it's so complex in many
So
ways. You
complex.
mentioned the idea around compliance, doing things with compliance, education internally about the differences in rare disease. We have to look at things differently as well too. I mean, the FDA is a great example of how they're really prioritizing rare disease and thinking about it different, right? So we have to do things as organizations and be willing to not assume, like you just mentioned earlier, about that. But that requires a lot. So I know we can't tackle all that today. I want to go
Mhm.
back to the co-creation comment that you made, right? Well, around patients. So when we talk about the patient voice in rare disease, moving it from feedback to co-creation, what does that mean? Tell us more about what that means, or how you've seen that play out.
Yeah, I mean, I think co-creation at its core is very consistent with what the words sound like. It's, not designing and then going back for feedback and saying, I think we've got this beautiful thing. Can you give me some feedback on it? Right? It's really, rolling up your sleeves, getting in the trenches with the patients who know this, with people who know this best, right? They truly are people with lived experience, or I'll mince words, Chad. I love to do this, like, as well. Like, I think some communities will really even argue with the concept of lived experience. Particularly, I've heard this in the ALS space, because it is not past tense. It is ing. It is living experience, right?
Mm.
And that, because it evolves for them every day, and that uncertainty is the only constant in their lives. But I think co-creation is at its core acknowledging that and really rolling up our sleeves and finding compliant paths forward to integrate that voice, those people, those perspectives into everything we're doing at the inception of that activity, not at the end of it, right? And I think there can be, we can need to go retrospectively as we evolve and implement things, as we go forward and continue making ourselves better as organizations. But in a ideal scenario, we're integrating that voice, not just one, but multiple, from the beginning of something, whether it's the strategy development, the trial protocol, the trial design or protocol development, whatever we're talking about. That perspective is truly invaluable, because unless you walk that walk, you don't really have the same perspective to challenge assumptions. But we need that combination. We need that partnership, right? To get to where we need to be.
Have you seen um do you have any examples? And it's okay, I know a lot of this is navigating new waters, right? I mean, have you seen, or do you have practical examples of how that's played out, or you've seen companies do that? Or is it just, do you have certain ideas that could potentially be explored when we talk about that co-creation and what that might look like? I have a couple that come to mind, but I'm curious your
Yeah.
thoughts.
I mean, I've got some things I think about where people realize that at the time that something started, it wasn't necessarily integrated in this way. But boy, do we realize like that now we want to go back. And so I think there's some on that front. I've been doing some studying in other spaces over the recent, couple months and thinking through even, spaces that I hadn't worked as intimately in, like ALS or SMA, DMD, as you said before. But, some companies are doing this in like registry studies that are very common, or natural history studies that are very common to kind of work in tandem with their trial development. So you've got that better comparator and to support you in times when you don't have that placebo controlled element. But I think in some places, people are really not only taking that so seriously because they need it from a regulatory pathway standpoint, right?
Mhm.
That's a critical importance for a company, but also what am I doing with those data? What am I learning from it? And how am I getting that back into the world? And, I've seen some companies recently, over the past few years, really taking that work and really starting to publish not just the learnings about the natural history of disease, but what are perspectives, for therapy, if we're going to be required to do a placebo-controlled study, what is the community perspective on how long is too long on a placebo as I'm designing my trial? Doesn't mean we can meet them at where they necessarily want us to be, but really understanding, getting that information out into the world. And I think that's also really helpful as companies begin thinking about navigating conversations with regulators. Like, this is what we learned from the people who lived this life, right? And this is what we think. This is how we think this could inform our design. How does that look to you? And that collaborative designing element. And then on the other side, like, we're not all going to get it right all the time. And I think especially as we continue evolving in this space, we're going to have older initiatives or studies that they're baked, right? Like we've already gotten where we are with them. But we're not lost if we didn't do that in the beginning. I think we still have an opportunity to kind of go to the community and recognize, hey, we didn't necessarily do that, but here we are. And I think one example that really comes to mind is thinking back to some of the work I did in the ALS space, an ultra rare form of ALS, and thinking about how the team, well before my time there, but how they were really thinking about designing this study. But what that really came to, the patient interview component of some of that work really turned out to be so very critical in helping the team understand in that instance. It was a failed phase 3, a missed primary endpoint. I shouldn't say failed. It was a missed primary endpoint for the trial. And it was really, I think, stumped the entire team because the outcome of that just it wholly did not match what the team knew of the earlier data, and a p-value that was abysmal, right? Like about as far away from statistically significant as you could possibly be. And I think by going back to look at what they had integrated for patient interviews, they were able to start learning clues to help them understand what was actually happening, to help explain why that primary endpoint was missed. The trial was too short. Understanding the pathophysiology of what's happening with the target engagement and then the subsequent biomarker knockdown, and then how long it took to see the clinical manifestation because of the body's clearance time there. So a lot of really important learnings that I think some of the biggest clues to how to dig into the data more deeply came from the lived experience, came from those voices of like what it was like being in this experience of trial.
So in an ALS trial, you were talking about like how long before it goes open label, maybe. Like with ALS, like you said, I mean, some of these people, their life expectancy is 2 to 5 years after diagnosis. What's a reasonable length of being the one on placebo before you can switch over to the active, according to the patient community?
Well, I think I will answer that. I think in an ideal world, if I'm living with that disease, my answer is that I would prefer not to have a placebo control, right? Like you hear that, not just ALS, you hear that in many spaces. And most communities understand that to ensure that the science can support the safety and efficacy of a given therapy, that placebo control is so critical, right? I mean, I think teams are coming up with really innovative solutions with platform trials and other things to repurpose placebo groups, et cetera. That's probably a conversation for a different day, but innovative solutions. So I don't know that there's a singular answer, but you asked specifically in the ALS space. I think one of the most important advancements over the past years has been really more deeply understanding that heterogeneity of disease and how, people with different mutations that are associated with ALS and variants of those mutations, and then what biomarkers look like in terms of signals for axonal injury and neurodegeneration, like what that looks like. And I think the biomarker space, not just, we hear a ton about neurofilament light chain or NFL in the world right now. That's one, right? There's a lot of biomarkers out there, imaging biomarkers, blood and fluid biomarkers, all kinds of things. But I think things like NFL and other biomarkers, the more we learn, the more those things are going to be able to really shift the paradigm in clinical research, not just in ALS, but in many spaces, so that we better understand how to design trials so that we can stratify and shorten the time on trial or shorten the time on placebo so that we can be more likely to succeed with trials with less time on a placebo, because we know we are looking at the right group, right? Like we've got this study enriched in the right way. We've stratified in the right way, and it's data driven. By really more deeply understanding the underlying pathophysiology of disease.
And that's got to be the hardest part too, is like when nobody wants to be
Yeah,
on placebo, but
right.
for the purpose of determining if this works and is safe, that's just got to be the hardest part.
Yeah. You made mention earlier about where it should start, and then the reality is it doesn't always start that. It rarely starts at the very beginning. One of the things I have seen is for like crossover advisory boards, right? Where it's not just a medical advisory board or it's patients from a marketing perspective. It really is bringing those two
Right.
together, a joint advisory board of like, where do we take this next, or what's another indication, or whatever it might be, right? That'll help support where access to this medication is easier, things like that. So
Yep.
being willing to do those types of things are just small. They're big steps for some, but that is a way. Let's be honest, once the companies start seeing the benefit and the fruit of that, of having those, I think that will also open up the willingness to invite them in
Mhm.
at an earlier stage. It's hard. Change is hard, right? And I think that where you have to be able to, as you mentioned earlier, flex, pivots at any moment, right? It doesn't mean that
Yep.
things are failing at that time. It's just you have to learn some of these things in the midst of it, and it
Right.
is. With the therapeutic areas, time is everything. And if you don't have that in order, or they don't have it, then you can't get it back, right? So you can't
That's
get
right.
over what it is you're trying to treat back. And so the
That's right.
urgency has to be there. And so it's just how do we take one small step forward,
Yeah.
to really ensure confidence and the reason why. If patients are at the center, like they are in the mission statement, then we need to really take an honest look and say, okay, are we doing the
Yeah.
things that we say that we ascribe to, right? So
Right.
anyway, that's a
Yeah.
rant for me. What are you about to say, Mary? It looks like you're about to pipe in on something.
Oh no, I'm having to make notes of things I don't want to forget to ask
Okay.
or to
Well,
bring
then
up.
ask. Go ahead and ask. And
So I keep getting back to the patient um, uh, involvement in things like trial design and feasibility, and uh, secondary endpoints. Maybe where should pharma companies really be relying on the patient communities, their caregivers, for their input into those kinds of things?
Well, I'll get on my soapbox for a moment. I think in an ideal world, the question is slightly reversed of where should we not be seeking that input? Where should we not be? Because I think that broadly the answer is everywhere. It should really be shaping everything that we do. Um, I mean, and the individuals with this experience are not largely, they are more knowledgeable, have even experience navigating medical settings than many providers because they're having to do this day in, day out, unpaid, mind you, right? Like they also may have jobs of their own or not because they've had to take on caregiving as a full-time role. But I think, in terms of trial design, I think from the inception, like thinking about what is feasible, what's the assessment schedule that makes sense. Can I expect somebody to travel every 2 to 4 weeks to a center that's 4 hours away, rather than finding a surrogate center that could help with some of the things if we have satellite opportunities or whatever? But even beyond that, like, what are we looking at? What endpoints matter to people? It may not be able to be the end all be all primary endpoint that a regulator is going to need that's extremely well validated and accepted from a regulatory approval standpoint as an efficacy endpoint. But we really should be, and agencies, regulators expect us to be looking at things that matter to patients, whether that's patient reported outcomes or PROs. But ultimately, what we're included, if you go to the communities that are really living this experience of whatever disease, DMD, ALS, whatever we're talking about, and you've got 5 things included, and they look at that list and they say one of them matters, then we've missed the mark, right? But there's also the consideration that is a really big challenge, I think, for companies. Sometimes that experience of what matters most to me as an individual, there's not necessarily something easy to measure, right? Like, what does greater independence mean? There are some scales out there. A lot of times they're not tailored or validated in a specific disease, so they don't necessarily capture, if they're looking at upper limb mobility versus lower limb mobility, and you've got a disease that doesn't quite hit the mark with the way your body progresses. I mean, there are all kinds of things that can challenge that. But before we can make those decisions and know that we've got it right or wrong, we got to know what people think about what matters to them, right? And I think that should be helping us to inform the selection of endpoints, primary, secondary, even exploratory, so that voice is also helping to really accelerate our learning in how this clinical research paradigm is shifting over time. Because those exploratory endpoints, I think, can also help us do that.
Yeah. How do you group things? I think that's when we're talking about PROs, right? Is there a way to bucket them versus, because you're right, when every patient's dealing with something that's really unique and specific to them that matters the most, right? So is there a way to do that? That would be one. And then what can you do from an objective standpoint? Like it's not necessarily maybe it's for caregivers, right? Missed days, missed
Right.
work days or things like that. Right. You start looking at those types of things from more that quality of life that are objective.
Right.
I think the biggest challenge is subjectivity, right? And even I think about doing a scale of one, some type of Likert scale of 1 to 5. Like I want to put 1.5 or 2.5, right? And it's not going to be. It could be the day, not the past 90 days or since your last visits. I mean, there's so many challenges. It's really complex. Maybe technology helps advance that to some point as far as trackers. I know there's been, those have been implemented along the way in different therapeutic areas, but we have to figure out ways, not necessarily for us, not for the patients, but how are they going to get coverage of these things? How are they going to, all those things from a financial perspective, because these are not cheap medications as well too. Let's be real. And it's a big investment on from companies to create these molecules to take a risk. So there's just so many different factors, but how do we set how do we set them up, the patients, so they can receive the care that they deserve. So it's a challenge. Let's be honest about that. And it's not one that's easily solvable, but it is one of those things that it's like, what can we do, like, as far as it depends on us and within medical affairs. And we haven't even talked about how that even fleshes out in other parts of the medical affairs organization. So maybe we should speak to that a little bit briefly, something like that.
Yeah. So I was curious, especially for our listeners who may not be working in rare disease, because this is very, very informative for them. What makes the MSL role uniquely important in rare disease as compared to like a broader, non-rare condition?
Yeah, it's a great question, and one that, Chad, I know you and I have had a lot of discussion around this in terms of the importance. But I think, the MSL role is built on that deep connection to the clinicians and the whatever space they're working in. But in rare disease, MSLs have a really unique job, right? And it's probably one of the best in the industry, if not the best in the industry. But they're bringing to the table, one, I think, the KOL community and clinician community in rare disease in particular, they truly expect whoever they are talking to, they expect extreme subject matter expertise. And I think our MSLs are equipped like nobody else in the business to bring that. But once you've had that opportunity to build that deep relationship, which in rare oftentimes can last for a very long time. There are people who will stay in that space for years, even if they switch companies, because they want to stay in neuromuscular or whatever. So there's a lot of overlap between some of these diseases. So they're talking to the same providers, even if they're moving jobs, but those relationships can really, be very deep and very, very long lasting, which is so critical for the business, because in those facilities, in rare, it's not just about that highest level of the totem pole prescriber. It's actually probably even more importantly about the multidisciplinary care team. So they have these rich relationships with the entire multidisciplinary care team, the genetic counselors, the nurses, the study coordinators, the neurologist, or whomever is the physician at the helm of that clinic. All number of folks that are involved, PTs, OTs, RTs, all of those folks. And really, what that allows them to do is be the first observer of these early indicators or patterns, right? And I think that's one of the most critical pieces is building systems and cultures in our teams, in our businesses, that really amplify the qualitative information in that, right? Because you hear something from one provider and it's like, well, that's a little different. And then you hear it again, later in the week or next week. And an N of 2 becomes an N of 3, but those become the early indicator patterns of a new gap that we didn't understand, or a new hypothesis we can formulate to really start to test a new approach. Or if it's something that's very clear, and we escalate, the MSLs trust the environment, and we can build that culture of trust and respect and mutual admiration for one another, we can really move that to a place where it can very rapidly help us pivot strategy and advance things more quickly, which from a launch readiness standpoint, and teams that are often very, under-resourced and rare, because we need to do this with very lean teams to make it work when you're talking about serving a very small number of people. From a business model perspective, that is really, really critical. But it can't, the ability to do that is contingent on the relationship between the field team and the medical director office, and the system, the medical director leaders or other leaders across the business, making sure that systems are in place to help us synthesize the medical insight, which is the true currency, right? Like that is the currency that helps us to pivot strategy very rapidly.
Yeah, as leaders too, there's so many different battles that we need to fight, or hills we choose to try to die on. This is one I think that really is important. There is a distinction between a rare disease focus, and you talked about the expectation of being the expert. I mean, the reality is it is 100% of the company's business and focus. It's likely the provider's 5%, 3%, 2% of the people. Now, obviously, centers of excellence will still have more, but even then, I would say it's probably 20%. It's not 100%. In very rare cases, is there someone that's solely focused on a specific rare disease, right? So, the expectations have to be different, and the understanding. But to your point, you have to have systems that are set up to be able to tell. It doesn't excuse, or maybe drive a mindset of laziness by any means, because it may be 3 engagements versus 13, right, a week. But I mean, do you have systems that can communicate, and have you equipped your team to go out and be able to have those deep conversations, or are you forcing them out the door, trying to get them just because you want to get, you've got timelines to meet. You've got you're focused more as a, sales support versus really, a true difference between church and state, right? I mean, there's just so many different factors on that, but we have to, as leaders, we have to really fight that and continue to reinforce the difference. We have to be able to communicate that as well too. So, just like MSLs have KOLs external, our KOL, we should treat other leaders within the organization as our KOLs, and really, do a great job in educating them and keeping that at the forefront. So there's a lot of ownership, and we need to function as a full medical affairs organization, not individual units and functions. Yes, we all have different responsibilities, but we all should be working, and our goals should all be tied together, right? I mean, because it really is about, the science and not, individual, contribution, especially in rare disease, right? You talked about being, lean in nature, in many ways. So any thoughts or comments on that?
Yeah, I mean, I think that I think another observation in terms of what the community and in rare disease of rare disease clinicians and providers really wants. I know for in my experience, and you may have a different perspective on this, but oftentimes the visit length is, especially for those folks that have really excelled in developing that trusted scientific partnership relationship, those visits often last much longer. So if we're thinking about traditional reach and frequency type metrics, right?
Yeah.
Like it can be you could actually end up setting up a scenario where you're shutting down the opportunity for insights just to set up the opportunity to get to another person, right?
Yeah.
Or another facility. So I think that's a really interesting thing. But in terms of the insight currency, I think the MSL has a hugely important role, and those insights are not just about pivoting our strategy and tactics and all of those things, but it's also really helping us to learn how to navigate, where do we need to push the innovation limits and go to our legal reg compliance partners to really have some great conversations around what is our potential? Do we have a compliant path forward to do a new initiative? And the insights are not just nice stuff to have to bring to that conversation. They actually are the foundational rationale for the requests, right?
Yeah.
Like it becomes the rationale, because I'm not telling you I want to go do something new and innovative because I think it's just fun and I want to go do it as a leader on the team. My community is calling for it. And here's 30 insights or 20 insights or 5 insights that are brand new that tell me that. And we got to act rapidly, because if we don't, we're missing the boat to support this community.
Yeah. I'll say one more thing, and I know this has been a great conversation. We've got, just a few minutes left, and there's a few other things I want to talk about, but I'll just say, when you think about systems too, I think that, we talk about how important insights are. I think it's crucial for, MSLs to see where their insights were impactful as well too.
Yeah.
You've got to close that loop, or they're going to quit
Yes.
wanting to do that. So when we think, it's not just a system to capture it, it is what came from it. You're saying you want quality. Well, what what's the result of getting this information and being able to communicate that way. It's fun, and that means alignment on key insight questions. Everything's on strategy, et cetera. There's a clear understanding of why we're going after something, what we're wanting to learn out of it, and then the impact that it has. Not everything is going to be put into place. I know there's got to be business decisions, but we have to communicate that. If we're really saying that that's where the value is, that's where internal medical affairs really has to do a great job on communicating, not only to the cross-functional partners, but then back to the teams that actually provided that information. So,
right. It's got to be, I fully agree with you. It's got to be a continuous feedback loop that, starts, if you want to think about it starting with field and then informing, that you've got to do the synthesis and analysis of those insights. AI, by the way, I think is going to be a really important tool for that to help our efficiency and frankly, more quickly identifying like next best action kind of ideas. But if we stop at what you did informed X, Y, or Z, and we don't feed that back to the field in terms of how we're having those internal conversations or what the pushback even was on X, Y, or Z initiative that we thought about, I think we're losing the opportunity to better build culture that has resilience and consistency and maintains the passion that people really bring to this space, I think.
yeah.
When you were talking earlier about how, when we were talking about like how rare is different from the bigger diseases, you talked about how important not just the KOL, it's or the provider, it's the whole multidisciplinary team. And it seems to me that's different in rare disease inside of a pharma too. Your medical and your commercial and your marketing and your advocacy and all of these teams seem to work a little bit more closely together. But you still got to be careful and we've got to have guardrails in place. What do you think are some of the areas we need to be most aware of to not get in trouble? Compliance type things.
Risks. Yeah. I think one probably more obvious and consistent one that will come up is just how institutions and providers and clinic teams who are in rare disease space or ultra rare disease space, how they expect you to come to them, right? And we have very clear compliance guardrails in terms of interactions between medical and commercial, in particular field medical and field commercial, and they're there for very, very good reasons. But in rare disease, providers are often asking for things like, I've got 5 questions and I've got 15 minutes and I need to have all of those answered in one spot, right? And so how are we proactively planning for ways of working that allow us to adhere to these very important guardrails to make sure that we can continue, we're compliant, so we make sure we can continue doing the good work that we want to do with these communities. Not for them, but with them. I'll kind of live by my own code here. But how do we do that in a way? And I think that partnership, some of the strongest and most regular conversations I have in day-to-day work when I've been in medical director office roles, et cetera, are with my regulatory and legal and compliance partners. Like in some instances, every day, every other day, you're on calls and really working together to think about, hey, we've got this learning coming in. I'm thinking about this based on what I'm talking or learning from our team. What do you think? Like, how do we get there? How do we kind of navigate that so we can find compliant paths forward? And then I think also in rare, inherently, a lot of times these data sets can be incredibly complex. Again, go back to that example of a missed phase 3 primary endpoint, an extremely complex data set that had to be worked with to understand even like how do we know the flow of this pathophysiological story, let alone communicate it externally, right? Like how do you really work to systematically understand that? But by nature of that complexity, there can be a lot more sensitivity, I think, around like whatever we're educating on or however we're saying things in the external world and who is saying things in the external world and to whom, if it's an advocacy organization, clinician audience, patient or community audience, what is okay, and where are we potentially at higher risk for something that is more making a claim that can't be really, truly systematically founded in the evidence that we have today, right? So I think those conversations are complex. They're complicated. They're intense, and they're probably the most important things that we can do to make sure that we're doing right by the community and not overpromising, but living to the code of learning fast and pivoting on a dime where we need to.
We have. I'm going to summarize it in a little bit quicker fashion on this. Not that what you said was extremely true and accurate. No. I mean, but as an organization, we have to be able to say yes if versus no
Yes,
because, right?
yes,
We can't just
absolutely.
assume like this is just because this is what we're comfortable with means that that's the best for the people that we ultimately serve, right? And so I
Right.
think that we have to like even but that comes back to building relationships internally as well too, where your
Absolutely.
compliance and regulatory people trust you,
Yeah,
and then you can be able to push back or like what's driving you to say no to this,
that's right.
or where is the evidence that shows that this would put us at risk? Help me
This would.
understand those and having those conversations. We can't versus, um,
Yeah,
versus just doing what's been done for the past 20 years or the past 30 years, just because
right.
that's safe and keeps us out of trouble. That we
All right.
time is, I mean, time, the clock is ticking for these patients, right?
Yeah, the
So,
clock moves different in rare disease, and most of them will talk about the whatever fill in the blank disease clock, the ALS clock. It's a faster clock. It's and I'll take it. I like the analogy, Chad. I'll take it maybe even a step further. It's the no. You, you talked about the kind of the no because I think maybe even in some instances is the no, not right now because, right?
yeah.
And then that gives an opportunity to understand where the gap is and continue collecting data if that is what the community is calling for, to potentially have the foundational evidence that we need to move the needle to a yes.
So it's for another time. It's the question is how to appropriately navigate these conversations. What can set people up to succeed? To
Yeah,
have those like, can we agree that we're on the same team before we get started and that
that's
we have
right.
the same right? So bringing on defensiveness. I mean,
Yeah.
we could have a whole podcast on that. Teresa, this has been fun. I wish we would have had you on to talk about something you're more passionate about, apparently, because I mean, rare doesn't seem something like it seems like it's just something you do. It's not really who you are. No,
Right.
really, really good. A lot of challenges. So as we wrap up, what if there were one thing that you would challenge medical affairs leaders or anyone within a medical affairs organization, field, whatever, what would it be around thinking about patients living with rare disease?
Yeah, thank you. That's a gosh, there's so many things. I think for me, it's really ensuring that we live by the code in our core, our North Star, that these individuals with rare disease, with any disease, but especially rare disease, they are not just passive beneficiaries of innovation. They are really, not to be cliche, but they're really the architects. Like they are the lead architect. They understand it better than anybody else. If I with a PhD in whatever it is that we have, like that level of knowledge is so critical. But when we pair it with the power of the lived experience, we can truly move mountains. And the rare disease communities that we're serving, as Mary said earlier, they demand excellence, and we must achieve that. They deserve that and more. And I think it's our responsibility in medical affairs to really ensure that lived experience doesn't end as a conversation, but that it's truly we're translating that to action so that we can support impact where these communities need it most.
What a great way to close today. Patients demand it, and we should demand that of ourselves as well too, as organizations that are serving these patients. Teresa, thanks so much for taking time out of your day to connect, share your experiences. Really appreciate you joining us today.
Well, thank you. It's been a pleasure. I think talking about something so near and dear to my heart. It's always fun. So I appreciate it, and thank you both for what you're doing on this show. It's really been fun to watch it come together and see you soar.
Yes.
Yeah, it's been hard. It's been a hard journey, especially with my counterpart, but we've somehow survived. So, just joking, Mary. I love you.
I know you're
Anyway,
just joking.
I know. Well, thank you, listeners, to that have listened today for joining us for another casual conversation. Remember, leaders don't develop in isolation. Leaders are leaders, and that's what our focus is here at MSLead Chronicles. So until next time, lead well.